So everyone, we have the privilege of hearing again from Elliot Overton, who's an expert on thiamine and the use of thiamine in treating disease and disorders. And last week, as you recall, he gave us a great overview and an introduction to treatment. And I noticed that a lot of you have started experimenting. I got a lot of great feedback from last week. So this week, we're going to go into more detail about how to treat our patients. And Elliot, correct me if I'm wrong, but next week, I think that you said that you would be able to come back again so that people would be able to ask you specifically about different patients of theirs. Is that correct? Wonderful.
Yeah, of course. Yeah, I'd be happy to.
Wonderful, wonderful. So, okay, Elliot, I'm giving the chair to you. And okay. Thank you.
Okay, so let me just share my screen and make sure that everyone can see what I'm looking at. 1 second. Right, so share screen. This guy. Okay. Right. Move this guy up here. Okay. Everyone can see a presentation, right?
Yes.
Okay, perfect. So today we're going to pick up where we left off last week and look at the art and the science of megadosing thiamine. Just a very quick recap before we look at kind of what we're aiming to achieve today. To go over, or in a nutshell, what we discussed last week was that thiamine, this essential cofactor for rate-limiting enzymes involved in energy metabolism, it's super important. And if you don't have enough of it, your cells cannot make energy. It's as simple as that. The demand for thiamine goes up with what we call high-calorie malnutrition. This is another way of putting refined foods that have had their micronutrients removed from them. Pretty much most of the Western world subsides on this kind of diet. We have alcohol. There are other things which can also increase the demand for B1. One of those is surgery. It's well established that people who have gastric surgery or really surgery of any kind, because of the demands that that's placing on metabolism, it can increase the demand for B1 and induce a deficiency in some people. Illness, chronic illness, any kind of chronic infection or acute infection, chronic or acute inflammation, excessive exercise. You will probably know many people who push themselves to the limit, marathon runners, etc. These people are notoriously susceptible to becoming B1 deficient. The same thing goes for bodybuilders and some other random stresses such as UV light exposure. Now, what we also looked at was how a deficiency in this B vitamin, not only because it can cause a bunch of different symptoms that can be quite difficult to identify, but really selectively targeting the lower regions of the brain. And those regions of the brain are responsible for coordinating, modulating, controlling the autonomic nervous system. And this gives us some insight into how even a mild insufficiency in this 1B vitamin can lead to such a systemic or wide array of symptoms which are seemingly non-specific. So we went through this concept that dysautonomia, because the regions of the brain responsible for controlling the autonomic nervous system, when you have problems with that system, it can relate to an underlying cause, which is a lack of B1. And these are a collection of the symptoms that can present, ironically, they are classed as dysautonomia symptoms, but they are also classically the same symptoms as an underlying, even mild thiamine deficiency. Now, we spoke about this book. Again, if you want to learn more about this topic, I highly recommend checking out these two researchers. This book was one of the things that really spurred me on to research this further. Finally, we looked at how B1 possesses this universal anti-stress property. So it's conserved among plants, animals, bacteria, all life. It would seem uses B1 to respond to stresses. And the thiamine-dependent enzymes in the human body are uniquely sensitive to oxidative stress. They're sensitive to toxins and things. And we see that there's this concept that we discussed towards the end of last week's discussion, this idea that factors other than the diet, factors other than a nutritional deficiency, can inhibit or inactivate these enzymes. And what that essentially does is it produces the equivalent of a nutritional deficiency at the cell level regardless of what someone is eating. They can be eating a nutritious diet. They can be doing all of the things right. But if they have some underlying pathology, underlying toxicity of some kind, then that can ultimately produce the equivalent effects to a thiamine deficiency. And that can potentially be remedied by using thiamine in medicinal quantities. So the aims for today's presentation, I'd like for it to be much more practical. Ideally, by the end of today's discussion, you'll have a pretty good foundation, a solid foundation to start using this therapy in your patients. I'd like you to be able to feel confident, knowing which forms to use, knowing how much to use, knowing when to use it, when not to use it, which forms for which different conditions. There are some nuances here, so we're going to go through all of those nuances. The first aim would be to understand the difference between the concept of nutritional deficiency and functional dependency. And this is something that we've briefly touched on before, but I'd really like to drill this down because I think that nutritional deficiency is there are some wrong ideas about it, and we need to reframe the way that we view this to really understand why people can respond with such an array of different diseases to this one vitamin. It really, we need to make sense of it. Learn why supraphysiologic, or in other words, mega doses of this vitamin can be necessary. Sometimes lower doses are completely ineffective, and we need to understand why that is, and you need to understand what to do about it. Next, to distinguish between the different forms. So there are several different types of thiamine on the market that have been researched heavily, some not so much. And it would be good to really lay out exactly what the differences are, including the pros and cons, so that you will know when to use which form for which different person. Learn how to decide which forms for which conditions. Again, if you've got someone presenting primarily with gut problems, you're potentially going to use a different form to if you have someone with peripheral neuropathy, and we'll see how that looks in real life. Learn how to increase the dosage. So we're going to look at where you would start megadose protocol, or whether you're trying to, depending on which different type of condition, what dose to start with, what form to start with, and which other nutrients might be important along the way. How to identify people who are potentially not going to respond to this nutrient. And there are a couple of reasons why that might be. Not everyone does respond, and that's something that I want to lay out first of all, is that probably only a minority of people are responders to this, but those who do respond beautifully. And finally, learn what the paradoxical reaction is. You might have heard me talk about it last time. Learn what it is, how to spot it, and how to manage it. And there are ways to manage this. Okay. Once again, if there's anyone who has any questions midway through, feel free to stick your hand up or chime in, and I'll do my best to answer any questions that you have. Okay. So to start off with, before we get into the nitty gritty, I just want to go over some basic definitions so that we're working with similar concepts. We're on the same page about things. So there is the classical definition of nutritional deficiency, and some of the patients that you're going to be treating with thiamine, they will fit within this category, and it's important to identify who those are because that's going to guide how you determine the treatment that they need. So nutritional deficiency, generally, it's known as in the case of someone who is consuming foods which simply do not provide an adequate amount to meet the body's demand. And there can be several reasons for this. It can be that the food that they're eating is insufficient in the first place. So we consider the concept of high calorie malnutrition, but it can also be that their demand is simply higher. Remember that we looked at various things such as stress, physiological stresses, psychological stresses, but also exercise, for instance. All of these things are going to increase the demand that someone has. And so the amount that they're eating from food has to meet that. There is also the concept of overconsumption of what we call anti-nutritional factors. So there are things in the foods and the drinks that we consume, certain medications such as metformin, additives such as sulfite. It's one known that alcohol or tea and coffee. These can basically block or inactivate thiamine in the gut and prevent the absorption of that. Okay, so if someone's consuming a high amount of these things, if they also fit the junk food category, then that's going to start ringing some alarm bells in your head to think, well, actually, maybe this person is suffering, maybe their symptoms are an underlying presentation of an underlying thiamine deficiency. Again, there's also other medications such as diuretics, which can increase the rate at which we're getting rid of this nutrient. And at the same time, other things which can interfere with the utilization of B1 at the cellular level, one of those being flagyl or metronidazole. Like I said last time, there's lots of people who react very negatively to that. they're generally prime candidates for B1 deficiency. Now, we have what we call induced deficiency. So this is generally got nothing to do with the diet, but it's also important to know. So these are also red flags that if you see patients with any of these things, then you should start suspecting, or you should at least consider thiamine as one of the causes of their issues. So we have underlying medical conditions which may not be related to B1 deficiency in the first place, but which have a negative impact on the way that the body handles it. So one of those in diabetes, we spoke last week about how diabetes causes an increased excretion of B1 at the level of the kidney. There are anything related to digestion. So if someone has inflammatory bowel disease, or if they have SIBO or malabsorptive disorders, this is going to be another red flag. Like I just mentioned, increased demand, so surgery, infection. If they're put on parenteral nutrition or IV glucose, these are two things which can tip someone over the edge if there's not enough thiamine within those solutions, or if IV glucose is administered without thiamine. There have been cases where people have been put into beriberi, or they've been tipped into Wernicke encephalopathy because it's just increased that demand too much. Okay. Now, here is where it gets very interesting. Here's my kind of the topic that I'm most fascinated by is the concept of functional dependency. Before we look at that, these are some of the questions that after reviewing the research and after applying this in super high doses several years ago, I was left asking myself these questions, right? So why does thiamine in sustained high doses work so well for such a wide variety of diseases? Because there really are. And honestly, you start applying this clinically, you will see that there are just a variety of different things that respond so well to this one single vitamin. It doesn't really make sense. It's bizarre. Not everything is a thiamine deficiency. And I'm not saying it is, but sometimes it does seem like that when you see such a wide variety of different conditions spanning through the different organ systems, responding to this one single vitamin. Is it merely addressing a deficiency, or is there something else going on here? And this is kind of the rabbit hole that I was led down several years ago. And I've come to some conclusions. We spoke about this last week. What I believe is happening at some level, at least in certain people with certain conditions, is that they're not deficient in the classical sense, but they are suffering from what I refer to as a metabolic block, a block on metabolism, a bottleneck in metabolism. And that's because this scenario that I discussed briefly before, thiamine-dependent enzymes inside the cell, for whatever reason, because they're so sensitive to these environmental stresses, they have been inactivated. They've been blocked, and this has become pathological. And there's a lot of research to back this up. I'm not going to go through that. We did touch on some of that last week. I've got a bunch of it in my videos, on my website, etc. So if anyone needs any information, I can send you lots of references. Just let me know. But ultimately, this is where I think the evidence is pointing to, is that we see this kind of this inhibition at the cellular level. And so in real life, where do we see evidence of this concept? The first place I would argue anyone should look at is the work of Dr. Antonio Cosentini. Some of you may be familiar with him. Unfortunately, he passed away during the COVID. I think it was 2021 or 2020. Now, he was an Italian neurologist. He had been treating a variety of his patients using B1 because he had delved into the literature going back many decades, and had come to some very interesting conclusions. Now, some of you may be familiar with this paper. Again, it is just a very small case report. It's looking at 3 patients with severe fibromyalgia. He published this in 2013. And what they essentially did was they started these patients on 600 milligrams of ordinary bog standard thiamine hydrochloride. That's the cheap stuff. That's the stuff that you can generally get from most health food stores. Their protocol was to increase it by 300 milligrams every 3 days. Okay. And what did they find? Now, if you look at this table here, it's going through the FSS score and the VNS score. So FSS, is the fatigue severity scale. And the VNS is the visual numeric scale. This is basically looking at the conglomeration of symptoms that people have with fibromyalgia, and they looked at before and after. And as you can see, the therapy, these people were not on any other medications. They had been previously on antidepressants, on pain relievers, etc., but they were taken off all medication. They were prescribed this therapy, just bog standard B1. They started at a moderate dose, and they gradually built up the dose. And within a fairly short period of time, you see that the fatigue severity score in I mean, in all of them has either halved or almost cut down by 60%. Okay. We see that the pain scores, there was one patient that went from 10, which is the most severe rating that you could have, down to 2 after taking B1. The results were nothing short of remarkable. Again, it's not a large scale study. They did apply for funding. Unfortunately, they were refused. But ultimately, to quote Costantini, he says patients 2 and 3 never reported any improvement until the dose was increased up to 1,500 milligrams per day. An abrupt improvement instead occurred at doses of 1,800 milligrams per day. So basically what they found, if you read the whole paper, they found that they started these 3 patients on a modest dose of B1 at 600 milligrams. It's not too high, but it is approximately 600 times what you would get from the diet. And they found that that within a couple of weeks, once these few patients managed to get up to the very high doses of like 1.5 grams per day, there was an all or nothing effect, in that their symptoms had not shown any improvement up until they reached a certain dose. So at 1,400 milligrams, no change. 1,200 milligrams, no change. But only when they reached 1,500 and subsequently 1,800 milligrams per day did they see an almost overnight improvement. Many of the symptoms practically disappeared overnight. And this is where it's really, really, really interesting. He says this therapy seemed to be characterized by an all or nothing effect. In other words, below a given minimum daily dose, there was no improvement observed. Now, these patients were kept on thiamine, and I believe that they probably continue to take it to this day, although I'm not sure. It didn't decline in its effectiveness. So basically, it took these people from being, some of them were bedbound in the fact that they had such severe pain and such severe fatigue. Now, it didn't completely abolish the fatigue, but it almost abolished the pain, and it greatly improved the fatigue in a very short period of time without any other single medication. And just to mention that none of these patients had evidence of thiamine deficiency. They looked at thiamine pyrophosphate in the blood. They looked at thiamine levels in the blood. They looked at numerous different measurements. They didn't have the symptoms of thiamine deficiency, yet you saw this positive effect. He also then went on to study a variety of other conditions. Now, he published 2 studies on Parkinson's disease, and that's really what he's best well known for. I will say that since his fibromyalgia paper came out in 2013, there have been thousands of people who have self-treated their fibromyalgia with B1. There are many groups and support groups and things online, and it seems to be pretty remarkably effective. I've personally used it in fibromyalgia, and it's very effective, like I was talking about last week. But when it comes to Parkinson's, like I said, this is probably what he's most well known for. What they discovered that in Parkinson's, they didn't use oral, they used injections of thiamine. They used, I believe it was 100 milligrams twice per week, which again is 100 times the recommended daily intake. They found that this therapy led to a considerable improvement in the motor part of the symptoms, ranging from 31.3% to 77.3%. Okay. And here is what he theorized. From this clinical observation, it's reasonable to infer that a focal severe thiamine deficiency due to a dysfunction in thiamine metabolism could cause a selective neuronal damage in the centers that are typically hit by this disease. In other words, not a systemic deficiency, but a focal deficiency, a localized deficiency at the cellular level, which will not be detected by blood tests. Again, a later paper that he published in 2015, 100 milligrams intramuscular twice per week in 50 patients. Again, they found that in some of the Parkinson's disease patients, they achieved complete clinical remission. Okay. Some patients with a milder phenotype had complete clinical recovery. I mean, guys, come on. This is insane. I mean, Parkinson's disease is notorious for the fact that there is no cure. You can only manage it with certain drugs, one being levodopa, which doesn't halt the progression of the disease. It doesn't halt the pathophysiology of the disease, you know? So ultimately, this is quite remarkable. Now, I had the pleasure of interviewing a lovely lady. Her name's Daphne Bryan. She published a book titled Parkinson's and the B1 Therapy. She was diagnosed with Parkinson's. If I remember correctly, I think it was in 2017. She was told that there was absolutely nothing that she could do about it. Fortunately, she came across the work of Costantini. She began using thiamine, and she is about 80 to 90% free of symptoms. And she has retained that ever since she started, I believe it was 2017, 2018. And so this is a therapy which can be extremely effective, yet practically no one knows about. And I believe that Costantini attempted to gain or get funding for large clinical trials. The Michael J. Fox Foundation was not interested. Most of the other medical associations were not interested, and it makes you wonder why when you have such a promising therapy. But ultimately, what I can say is that there are a lot of citizen scientists who are treating themselves for this condition. I would recommend going to my YouTube channel if you want to hear her story. Her book is very patient oriented. So she's not a scientist. She's not educated in biology or science or anything like that. She simply is approaching it from a patient's perspective. And there are literally thousands, if not tens of thousands of people who've used this successfully. I know that Costantini's team still use this to this day with their Parkinson's patients, and it doesn't cure it. Here's the thing. It doesn't cure it, in that these people generally require B1 indefinitely, and that when they stop B1, they may retain remission for, say, 2 to 3 months, but when they discontinue it, the symptoms come back. And this is something that I want to emphasize about fibromyalgia as well. It also seems to be the case. So we're not dealing with a classical deficiency. And this is the reason I'm saying this is so that you understand that when you start applying this clinically, you're going to have to differentiate between who is a classical or, say, non-classical deficiency and who is someone who has a dependence on this. I believe that what we're looking at is dependence. Just another couple of very interesting papers published by Costantini and his team, again, looking at the effects of thiamine on fatigue after stroke, Hashimoto's thyroiditis. They found that many of the symptoms could be completely reversed with B1, dystonia, essential tremor, and there are a wide community of people who are treating essential tremor. I've had several clients with this condition who noticed a fairly abrupt response to high-dose B1. However, they are also the type of people who require this long-term to maintain symptom, to not have the symptoms, basically. Again, what else do we have? Spinocerebellar ataxia type 1. It can really help with the dysautonomia type symptoms associated with this condition. Friedreich's ataxia, and fatigue and multiple sclerosis. Now, what I would say is that many of the symptoms of MS can be resolved if you use the right type of B1 and in the right dose. Now, something from one of Costantini's papers, and this is really why he was a free thinker, a thinker ahead of his time, I think. What he said was, we may suppose that the symptoms decrease when the energetic metabolism and other thiamine-dependent processes return to physiologic levels. Our aim was not to correct a systemic deficit of B1, rather to increase the activity of enzymes involved in cell production of energy in selective brain regions. What he's basically getting at here is that you do not have a systemic deficiency. It's not going to be picked up by tests. These people usually don't even have the risk factors. They are not deficient in the classical sense. Rather, the cells in the brain, or a region of the brain, or a region of the nervous system, for whatever reason, those B1 dependent processes are blocked. There's that bottleneck on metabolism. There's that metabolic block going on. And coming back to the concept that we spoke about last week, when you provide massive amounts, when you saturate the cells, you can reinitiate or you can reactivate enzyme function. And this is essentially what he was saying. Now, it turns out that there are other conditions, which we briefly looked at last week as well, which don't fit the classical syndrome of B1 deficiency. They don't fit the classical risk factors. One of those is Alzheimer's disease. Recently, $40 million grant by the NIH given to Gibson and his team at Berk to study the effect of benfotiamine on dementia, Alzheimer's. Now, a very recent paper and case report looking at amyotrophic lateral sclerosis. I mean, this is a real nasty disease. This is, I mean, if you were to ask me which thing I would probably least like which condition I would least want to have at any time in my life, it would be ALS, because ALS is basically a death sentence. At least from my perspective, there's very few, if anything, that you can do about it. At least from what I know, I'm not a neurologist, but from what I understand, there's very few things that can help with this condition. And it's progressive and it's degenerative. Now, it turns out that there was a case study literally published like this week, and it was talking about a patient or a case report that he had using benfotiamine in fairly high doses, and finding that this patient with ALS found very, very significant improvements in many of their symptoms. When they stopped the therapy, the symptoms relapsed. Okay, so it wasn't a deficiency, or at least what we think. At least it seems as though this person didn't have a deficiency, but it's probably this concept that we're looking at now. Again, very interesting. Another neurodegenerative condition, Huntington's disease, one of those other ones that there's really nothing that you can do about it, from what I understand. A pretty dire prognosis, but again, this was a paper published not long ago. It was 2021, late 2021, I believe. But what they identified was that there was some kind of a defect. Usually, I think it was a genetic problem with the production of an enzyme, a biotin-dependent enzyme, which gets thiamine into the cell. And what they identified was that ultimately, or what they think from the evidence, was that the driver behind Huntington's is an intracellular B1 deficiency in very specific regions of the brain, which is caused by a transporter defect, meaning that these people might be eating enough in the diet, but this transporter defect causes a lack in these very specific regions, and this is one of the kind of triggers for Huntington's disease. What they also found was that in the animal model, at least, and I believe that they have got a clinical trial on humans, which is being undertaken at this moment. They found that in animals, they could reverse the symptoms, at least in the animal model. They could reverse the symptoms by treating them with biotin and thiamine. Oh, sorry. I think I've accidentally clicked off the PowerPoint. Okay, there we go. Now, another one is long COVID. And this is probably people, or a bunch of people that you see. I know that I've seen a lot of them, at least since 2020. And it turns out that B1 can be another one of the very useful tools to help people deal with this. And we spoke briefly about vaccine side effects last week. It turns out that at least in people with long COVID, not necessarily from the vaccine, but in people with long COVID, there are numerous testimonials. I regularly get mail from people who have essentially followed my advice from my videos or my articles, and they have addressed what they thought was long COVID, but seemingly was an induced thiamine deficiency. You can look at these two interviews that I conducted not long ago. People whose health condition plummeted after getting COVID. And it turns out that when they came across my work, they started using B1 in the right form, the right dose, they addressed it. So a new way of looking at deficiency. Well, we know that deficiency can be caused by people not eating the right foods, people not taking care of their health. But what we have to consider is that there are some people with chronic illnesses who are functionally dependent, meaning that they need consistent high doses on an ongoing basis to maintain their health gains. In that when they discontinue B1 for whatever reason, and I don't know what it is, it could be transporter problems, it could be genetic problems, it could be a blockage, like a bottleneck, like we've just spoken about, it could be any of these things, but sustained high doses are needed to maintain mitochondrial bioenergetics. And there's a lot of research which clearly shows thiamine is this mitochondrial protectant. In other words, when you expose mitochondria to toxins, giving enough B1 can help to maintain mitochondria. So it's not addressing a deficiency in the traditional sense, but a focal deficiency or a localized, regionalized deficiency due to inactivation of those B1 dependent processes. Now, for this reason, functional dependence on thiamine is needed for sustaining health. So there are going to be a portion of your patients that you're dealing with who respond beautifully to this therapy. And they're going to ask when they can come off of it, when they've addressed their deficiency. And you will see that when they start to reduce the dose, their symptoms will return. And that can be a little bit disheartening. But it just seems to be true for some unfortunate people. And the way that I look at it is at least you find a natural substance which can help maintain someone's remission, get someone into remission and helps keep them there. Without degenerating any further. It would be amazing if we found a cure, but unfortunately, thiamine isn't the cure for a lot of people. So here's a comparison, and this is something that you might want to refer to when you're getting a good idea for when you're looking at patients, you're doing a workup, and you're trying to figure out, okay, is this person going to respond to this? And if they do, then how am I going to approach this? So there's very subtle differences behind the concept of deficiency dependence, but there is a lot of practical value to this. For instance, if someone has the classical risk factors, the history, the symptoms of B1 deficiency. And remember, we went back to all of those dysautonomia symptoms, the fatigue, the lethargy, etc., the muscle pain, which are not classically seen as a deficiency, but which can still fall under that umbrella. If someone does not have those classical risk factors, they haven't been eating junk food, they're not an alcoholic, they haven't got severe digestive issues, then it's likely that they're going to be one of these individuals who are dependent on it if they respond. Okay. Now, if you're trying B1, if you start prescribing a supplement and you notice an immediate response, oftentimes these people, when they notice an immediate benefit, people who notice an immediate benefit from a low dose, you're generally addressing a deficiency. At least that's what I found. And again, it's difficult to see underneath the surface, but this is just a working model that I've come up with. I don't know if it's exactly factually correct. It just helps me practically speaking. So if there's an immediate response, generally those people are going to find, or you will find that within a few months, they will no longer require B1 in such high doses. Whereas the people who don't have an immediate response, and in other words, have this all or nothing effect, like Costantini described, then these people, more often than not, they will be the people who require this long term. Oftentimes, if someone can reach a full recovery, as in they can stop the therapy, when they can stop the therapy and the symptoms do not return, then it would seem as though you were addressing a deficiency. Whereas the people who stop the therapy and then the symptoms regress, even if this happens after a year or 18 months, believe me, it can happen after 2 years. You can have someone megadosing thiamine trying to come off of it, and unfortunately they just can't. So these are the people who I would think are more kind of falling under this category of dependent. Now, success dependent on the form used. This is true among everyone. So something really important to know before we even head into this is that the forms are the most important, not the brands. Like I said before, the disclaimer was, I own a supplement company which makes thiamine. Well, ultimately, the brand does not matter. What's most important is that someone can get it. They can get a consistent supply of it. They can get, they've got easy access to this. But really, it's the form that counts, and different people notice different improvements with different forms. So we'll look at exactly why that is. Now, I just want to go back historically and look at a paper published in 1962. It's remarkable, actually. It's titled "The Therapeutic Use of B1 in Diseases Other than Beriberi." Now, I would imagine that some of these diseases were fitting this kind of concept of thiamine-dependent diseases rather than thiamine-deficient diseases. So people who required long-term B1 on a consistent level in a sustained dose. So it turns out that there were a bunch of papers published right from the 1930s, as you can see, in Europe, in the US, in the rest of the world. And it's looking at using B1 to treat diseases which were not classically based on deficiency. So not beriberi, not Wernicke encephalopathy. They were using it for all kinds of stuff. So here's a table of the things that they were trying it on. So it turns out that the doctors back then, the medical schools, were teaching that you could use vitamins as medicinal compounds. There's lots of really interesting research. Don't know if any of you have gone back into it, but if you go from like the 1920s, 1930s, 1940s, you see that the doctors were much more open-minded. At least as a general rule, the conventional medical system was not as tightly controlled as it is today. And so they were using natural compounds at their disposal. You see that they were using it for a lot of things. A lot of these things were actually successful. Unfortunately, this knowledge has been lost in favor of a pharmaceutical model, as of course, most of you understand. It talks about how 85% of neurologists, 72% of internists, and 81% of the group, including various specialties, were regularly prescribing vitamin B1. And again, this was when they thought that someone wasn't deficient, but they saw that someone just had a problem. So they saw, oh, okay, you've got nerve pain, I'll give you B1. Or, oh, okay, you've got premenstrual syndrome, or you've got preeclampsia, I'll give you vitamin B1. As it says, over 70 diseases and symptoms were listed as indications for B1 therapy. So this isn't a new concept. This is well established. It's been in practice for almost 100 years. Unfortunately, again, the pharmaceutical model, I think, has pushed this out of conventional thinking, and now it's relegated to the alternative. What I'd like to do is revive that if possible. So next, here's where we're going to start to get practical. So which forms of thiamine can you use? We're going to look at exactly what forms are available on the market, what the properties are, how you can use them, and what you can use them for, what the pros and cons are. Hopefully, at the end of this section, you'll be able to have a rough overview, a rough idea of what we're talking about when we say benfotiamine or disulfide derivatives. So the original research, it's important to know, is that practically every single thiamine derivative that you can get on the market was discovered in Japan. The Japanese are the world experts in B1. It was discovered there. We went through the history of it last week, but ultimately this was where beriberi was identified. It was researched. It was studied heavily. So during the 1950s and 60s, Japanese researchers essentially played around with lots of different types of B1. So this was B1 attached to different molecules, a variety of different molecules, which gave the B1 different properties. What they were ultimately trying to find out was how you could increase the levels of B1 in the body very quickly. And the problem is that when you gave ordinary thiamine, just thiamine by itself, or thiamine bound to some kind of a salt, which we'll look at, there are inherent problems with trying to get a lot of that into the body, into the brain, for instance, because the body has its own mechanisms which prevent the uptake of too much. So you have these transporters, and we'll look at those in more detail later on as well, but these transporters prevent the uptake. They become saturable. Whereas they were trying to come up with ways to bypass that system. They originally discovered that there was a type of thiamine found in garlic, and they called it allithiamine. And this particular type of thiamine had very interesting properties, lipid-soluble properties, which meant that it could essentially diffuse across the cell membrane without a transporter. And based on this model, they synthesized more than 10 different derivatives, and they studied the bioavailability, the different actions, and all of these. So all of the ones that you can find on the market were originally studied in Japan, usually dating back to the 1960s. And the original research on this was actually fascinating if you ever get to read it. But these included benfotiamine, which you've probably heard of. Another form, which is TTFD, which I would doubt that any of you have heard of, or some of you might have. And there's also sorbutamine, which is one that's well known among the nootropics community. And we'll look at exactly what that is as well. But here are the three main forms. From a clinical perspective, like I just noted, there are thiamine salts. Now, these are your bog standard types of thiamine. These are your cheapest, most readily available. You've got your thiamine hydrochloride, and you've got your thiamine mononitrate. Now, thiamine mononitrate is the most stable. For that reason, that's what they fortify most foods with. That's probably the most common. Whereas from a supplemental perspective, thiamine hydrochloride is probably the most common. So these two are super cheap, they're super available, and you can get these practically anywhere that sells B1. Next, you have the S-acyl derivative, which is otherwise known as benfotiamine. Now, this, again, discovered in Japan. It has been heavily studied in the West, and we'll go into the details here, but this is where a lot of the alternative medicine community, if they talk about B1, they will generally recommend benfotiamine. Finally, you have another class, which is referred to as disulfide derivatives. The reason is because these forms, if you look at the molecular structure, they contain a disulfide bond. This gives them extremely interesting, unique properties. And TTFD, sorbutamine, both fall under that category. Now, if we look at thiamine salts, it's really quite simple. So ultimately, thiamine is absorbed as is. So in the gut, you get a dissociation of thiamine from its respective salt. So whether it's the nitrate or whether it's the hydrochloride in the stomach, in the intestine, you get dissociation. You yield free thiamine. Sorry. Now that's absorbed via these saturable transporters, and there's only a limit to how much you can actually absorb. So the problem is if you are giving, say, 200 milligrams, the estimated bioavailability of that is only going to be about 5%. Okay, it's only about 5%. Now, there are some caveats here in that if you give 2,000 milligrams in one go, there is some evidence which would suggest that you can initiate a process called passive diffusion, which means that you get a massive amount flooding into the blood. And I do believe that this does happen. It seems to at least occur clinically that some people find that they need extremely high doses of thiamine salts, but they can get a lot of benefits from that. Here's the transport system that I'm talking about. So you have these transporters on the enterocyte, the intestine, and ultimately, any type of thiamine that you consume is going to have to be broken down to free thiamine. And these transporters are saturable, meaning that they can only work so much in a given period of time. So, for instance, within a 24-hour period, if you saturate them, then any extra that you take in is not going to be absorbed. So it's going into the enterocyte, then it's again passing through a transporter into circulation. But you also have these transporters at the level of the cell. So every single cell, the way that you're getting B1 into cells is you're using these transporters again, which are also saturable, and the brain. And this is where it gets super important, because as you saw, that a thiamine deficiency is most likely to affect the brain. And this is the problem that the Japanese essentially came up against, is that you have all of these people who have severely thiamine deficient brains, but giving ordinary B1 was just not enough, not sufficient to really turn the situation around. And so the fact that you have these transporters on the blood-brain barrier, the fact that you have these transporters at the gut level, at the cell level, it means that using ordinary thiamine salts is probably not the most optimal way to go. So the way to well, in fact, before we look at that, just to look at some of the pros, like I said, it's cheap and widely available, can be purchased in pure powder form. Again, it's dirt cheap. It's super easy to access, can be taken in very high amounts. So you don't need to worry about microdosing it. You don't necessarily need a milligram scale or anything like that. You can get someone, just take like a quarter of a teaspoon or something, and that's generally going to be 1 to 2 grams or something. It's very useful in people who are quite sensitive to supplements, and we'll look at why that is in a short while. But there are lots of cons to this as well, because at lower doses or even at moderate doses, the absorption is very bad. And you can see, because you can have someone who has very severe symptoms and you give them thiamine hydrochloride and it really doesn't touch them. It doesn't touch them whatsoever, unless it's super, super, super high doses. And I think this reflects in that. Again, it's not very good at penetrating the brain. So there's not a lot of evidence that it can increase brain levels. And if you're trying to increase the levels in the brain, if you believe that someone's condition is based in the brain central nervous system, then you're really going to want to use a different form. It requires transporters, and it's less effective at increasing active thiamine in the cell. Okay. Now, as I said, to achieve clinical effects, usually if you're using these in patients, you're not going to see any change below 500 milligrams. Now, if it's someone who's very deficient, then you might find that using a lower dose than that can improve things. Again, if you work in a hospital or emergency room and you deal with people with alcoholism, then giving them even 50 milligrams is probably going to turn the situation around. However, when you're looking at the conditions like we were speaking about, when you've got Parkinson's, you've got multiple sclerosis, you've got the neurodegeneration, chronic fatigue, fibromyalgia, etc., anything under 500 milligrams is going to be fairly useless. There have been doses used up to 4,000, so 4 grams per day. For what it's worth, the RDA is between 1 and 1.5 milligrams. So you're looking at 4,000 times the RDA. The good thing is it's very safe. So it can be useful. I use it as a basis for most of the protocols that I start with, and there's reasons for that, which we'll go into a little bit later. Next, we look at benfotiamine. Now, this is probably the most popular at the moment. It's very heavily studied in the West. And the benfotiamine, if you look at the chemical structure, so you see the thiamine molecule, benfotiamine is basically a thiamine molecule with this extra chemical group added to it. And what this does is it gives it some interesting properties. So as soon as it's absorbed into the body, it's acted on by enzymes, intestinal alkaline phosphatase, I believe. And what that does, it converts it into a very interesting molecule called S-benzoyl thiamine. Now, this has similar properties to the disulfide derivatives. Basically, what it can do is it can freely diffuse across the cell membrane. So it basically melts through the cell membranes. This occurs at the gut level, at the blood-brain barrier level, at the level of the cell. And so what you see is that when you expose cells to this, they end up absorbing massive amounts of B1 that they previously couldn't absorb if you're just looking at free thiamine. And for that reason, it is superior in practically every way to ordinary thiamine salts. Now, here's a rough overview of the basic absorption profile and what happens in the body. And it has its pros and cons. So it is also pretty widely available these days. There's a lot of companies that sell it. It's got very high bioavailability. There's a lot of research looking at non-coenzyme effects in that it exerts antioxidant and anti-inflammatory properties. It can increase the levels in the brain. And the concern is that using thiamine salts is just not a very good way to do that, whereas benfotiamine can do this. And it's one of the most studied thiamine derivatives. The cons are in that, personally, I have found from a clinical perspective, and I know that a lot of people, as part of my wider network who also follow my protocols and things, have found a similar thing, is that it just doesn't seem that well or that good at affecting the central nervous system, at least for conditions which are primarily seem to be based in the central nervous system, at least. So dysautonomias, etc. It doesn't seem to have the ability to turn that around as the other forms that we're going to look at next are. So I find it's very useful, specifically for conditions of peripheral neuropathy. If you look at the research, you see just in Google Scholar, you type in benfotiamine and you've got over 5,000 results. It's been heavily researched for its effects in not only peripheral neuropathy, they love it in Russia. They use a lot of it in Russia and Eastern Europe, I believe. But it's also been heavily studied for its effects in diabetes. So there's some very interesting research showing it can almost reverse many of the diabetic complications. And other forms of B1 don't seem to be quite as good at this. Now, Gary Gibson, like I said, his work at Berk, I believe it's part of Cornell University, although I'm not exactly sure. Either way, his work in the US has gotten a lot of attention. He's done a couple of trials on Alzheimer's. He's found some very positive results. So he's got a large amount of funding to use high doses in a large cohort of individuals with this condition. And it does seem to have some very interesting properties and a lot of promising effects. Now, the clinical effects, if you're looking at the effective dose, generally from benfotiamine, you're going to need a much, much, much lower dose than thiamine hydrochloride. And for that, the reason for that is that you don't have this issue of the saturable transport system. Benfotiamine can just basically be absorbed as is very early on. And so you don't have to worry about mega dosing. So you can find that some people respond as low as 100 or 150 milligrams. However, a lot of the research does for effectiveness in diabetic complications, for instance, they use anywhere from like 1,200 to 1,800 milligrams per day. Now, it's not very expensive. You can get it in powder form. So again, that's not necessarily a problem. And there are a lot of people who are super sensitive to supplements who do very well with benfotiamine. So it is a really solid form of B1, and it should be part of any protocol, I think, just at least as a secondary form, even if it's not the main one. Now, finally, here is we're onto the disulfide derivatives. This is a form which you may or you may not have heard of. It's very unknown. It's unknown in the West, at least. And it's the form that Dr. Derek Lonsdale, if you recall me speaking about last week, it's the form that he favored. It's the form that I favor. It's my favorite form. And because I've seen this form achieve things which no other form can. And this is the form which was heavily studied in Japan, and they essentially decided to incorporate this into their entire medical system. And we'll go into that a little bit later. But ultimately, if we look at what this type of B1 is, its actual name is thiamine tetrahydrofurfuryl disulfide. It's a long name. You don't need to really know that. You just call it TTFD. Now, it's a thiamine molecule here on the left-hand side, and it's bound via a disulfide bond. And this is important. The disulfide bond is really important, but it's a sulfur-sulfur bond with what's called a mercaptan group. In other words, a sulfur group. And this sulfur group is what gives it some very unique properties, which allow it to get to places that other forms of B1 don't necessarily appear to get to. So here is a very basic overview of what happens to TTFD in the body. Like benfotiamine, the absorption/bioavailability is estimated to be anywhere from 50 to 90%. Now, there are some studies which are looking at the pharmacokinetics and pharmacodynamics, which indicate that this is like 100% absorbed. And there's various reasons for this, because the sulfur group or the disulfide bond basically in a similar way to benfotiamine, but via a different mechanism, allow this molecule to basically pass through any barrier. So it's neither water soluble, or it is water soluble, but it has these lipid soluble properties. For this reason, it's referred to as fat soluble vitamin B1. Now, this is particularly useful for anything in the brain. Like if you've got a patient with a condition, whether it be head trauma, whether it be stroke injury, whether it be Parkinson's disease or something of that kind, anything which is brain or central nervous system based, TTFD is generally going to be superior for that. Now, of course, there's always context, but what you'll find is that you might try someone on HCl and benfotiamine, and it just doesn't work as effectively as if you use TTFD. And now the research has shown that it rapidly enters the brain, it rapidly enters most of the organs, and the sulfur group, this extra sulfur group, when it penetrates into the cell, it detaches. And this sulfur molecule can then be used on site for various things. It can be used as an antioxidant. It has mild heavy metal chelating abilities. So it has been found to enhance the excretion of mercury, enhance the excretion of arsenic and lead and cadmium. So there are some very interesting properties to this molecule. The only cons are really is that it is very potent, in that oftentimes you would need to start at a very, very, very low dose. Also, secondly, is that this sulfur group can cause problems for some people. When I say problems, I'm not talking about genuine medical issues. I just mean unwanted reactions. There are people who don't really suit this form for whatever reason, and they're generally the people who have problems with sulfur compounds anyway. So these are the people who have, for instance, issues with NAC supplements or MSM supplements, or they can't eat garlic, they can't eat onions, they can't eat cruciferous vegetables. Either it causes them gas or it causes them flushing or something like that. So this is generally not a form that I would start with, or if I was starting someone on this, I'd start at a very low dose. We'll go through exactly how you would do that later on. But ultimately, the clinical effects are usually even lower than benfotiamine. So if someone requires 2,000 milligrams of thiamine hydrochloride, they might only require 600 milligrams of benfotiamine, and they might only require, as equivalent to that, 200 or 300 milligrams of TTFD. And because I see these equivalents, I consider TTFD to be the most potent form of B1, because oftentimes people just simply do not need as much of it to achieve such good effects. So you'll rarely see any of the studies using more than 200 to 300 milligrams per day. There are some studies which go like above 1,000 milligrams, but that's extremely rare. Now, like I said before, it's not very well known in the West, and this is unfortunate because, like I said, in the 1960s, you had the Japanese who are the experts in B1. They studied all of these derivatives. They essentially synthesized all the different ones that we have in the West today. And for a very good reason, they chose TTFD as the primary form they would use in medicine. So starting from the 1960s, if you look at the Japanese literature, unfortunately, most of it was never published in English. I had to manually use Google Translate to basically search all of the Japanese scientific directories. So there's one called JStage, there's JGlobal. Most of them aren't in English. So a lot of the really good research is just, it hasn't even been translated. The abstract isn't even in English. So you have to basically translate the word that you want to know in Japanese, and then you type that into the directory, and then it comes up with all of the research. And then what you also have to do is then copy and paste the whole PDF, put it into DeepL or another online translator, and read the study that way. So every single paper, I would say probably 90% of the available literature I've read and have manually translated. And there's a lot of it, unfortunately, in Japan is it's behind a paywall, so you can't get access to it unless you're with a research institution and you pay a certain fee. And of course, I don't fall under that category. So there's some of it which even which I'd really like to read, but unfortunately, it's not available. However, what I would say is that they began studying TTFD in a variety of different health conditions, not classically associated with B1 deficiency. For instance, chronic constipation, gastroparesis, different brain disorders, fibromyalgia, ALS. They were using TTFD in a lot of these patients back then, and they were finding very interesting results. And I'm not sure why this was never translated into English and publicized in the West. Most of the research that you will find on TTFD is in Japanese, Chinese, and Korean. Now, back in the day, up until maybe the 1980s or 90s, they would refer to it in their literature as TTFD, whereas these days, oftentimes in the abstract, is just vitamin B1. So you actually have to go into the paper and scroll down to find either where they say TTFD or another word for it is phenylthiamine. Either way, it's the main form of B1 that I believe, at least from looking at the literature, that they use in hospitals and in medical clinics in Japan. They use it intravenously and they also use it orally. Now, I believe that there's valid reasons why they chose this over other forms. Unfortunately, again, like I said, this hasn't been translated into the West. And so people are hyper-focused on benfotiamine, whereas I've personally found TTFD tends to be more effective. Again, Derek Lonsdale was the first individual, at least the first American, to import this under FDA license into the US. So he began using this, I believe it was in the 1970s or 80s. He had direct communication with the Japanese physicians, and he was following very closely what they were using and the kind of results that they were getting, treating conditions with B1. So he got a hold of this and he managed to get an FDA license. He started using it in his at the Cleveland Clinic and began writing about it. And he's been a big proponent of TTFD ever since. Again, if you want to read about this molecule, then you can look at any of Lonsdale's work, and there's particularly this paper which goes through how this differs from other forms of B1. But ultimately, from a clinical perspective, you will find that this form of B1 is going to be most useful for anything relating to the central nervous system, like I've said, but also for the digestive system. So when you have this combination of central neurological dysfunction, you have it coexisting with anything in the digestive system, or you have one or the other. TTFD would be my go-to because it generally tends to be the best at reigniting the vagus nerve, at reigniting the communication from the brain into the down towards the enteric nervous system and the gut, and getting things working again. I've had some clients who have been constipated for 15 years. They've been going maybe once a week, maximum twice a week with laxatives. They start on TTFD, and within a couple of days, their lifelong constipation becomes daily bowel movements. And it really can be quite that effective, although it sounds too good to be true. Now, I personally did my best to compile as much of the scientific literature as I could. Again, most of it is in Chinese, most of it is in Korean, most of it is Japanese. Of course, like I don't speak Japanese, I also don't speak Chinese, and I also don't speak Korean. So my ability to interpret those papers was, I admit, somewhat limited by the online translator, but I did my best, and I think I got the gist of it. So if you look at this article, then you'll see that there's over 100 papers which have been published on the effects of TTFD for these collection of symptoms. And again, not all of these are going to be thiamine deficiency. In fact, all of these conditions are where researchers have used TTFD. Of course, they use them for Wernicke encephalopathy and beriberi, but here are the conditions which are not classically considered thiamine deficient, yet they've used it with good effect in this collection of stuff. And so again, kind of similar to what we had previously been looking at last time, this concept of dysautonomia and brain cell hypometabolism and a lack of energy. You see how a lot of these things are generally related to that. So, like I said, I regularly treat people with SIBO and other digestive disorders, specifically with TTFD. There is a lot of research showing that a B1 deficiency can cause reduced brush border enzymes, for instance, reduced pancreatic enzyme secretion, reduced gallbladder pumping out of bile flow. Again, this is taken from a video on my YouTube channel where I ask the question, is it SIBO or is it merely a thiamine deficient gut? Again, we look at all of these effects. These are all the things that you will see in someone who is deficient in B1. And again, sometimes it will only present in the gut. So, they may not have all the other stuff in the brain and heart and things. They may just have it in the gut. And so for this, TTFD is very, very, very useful. If you want more information on that, go to that video. It explains the basic mechanism of how TTFD is going to be working to restore gut function in every capacity. So, there are some potential cons, and this is something that I think we already looked at with TTFD, is that this sulfur molecule, like I said, it does have antioxidant properties. However, it needs to be processed. Now, when it's processed, there can be some potential issues. Now, I'm not exactly sure why this is. I've done a lot of research to try to figure out the exact pharmacokinetics, the company, or they're called Takeda Pharmaceuticals in Japan, who originally synthesized thiamine or TTFD. They did a lot of research looking at the way that it's processed in the liver. They came out with a lot of these metabolites. Now, there's not that much known on them, although they are known that they're safe. It's certainly not toxic. However, it's known that some of these, at least from the research that I've done, may contribute or may overburden the sulfur processing system in the cell. So, for instance, some of these molecules can convert into sulfite. Now, if you know anything about sulfite, it is a neurotoxin. It's something that's added to wine and other processed, or it's as a preservative in certain foods. Unfortunately, for people who cannot process it very well, it can be a real problem. There are some unfortunate individuals with genetic aberrations who have defects in the process, in the way in which they process sulfur compounds, and they will die if they're not treated very early on. So sulfite is toxic, and the way that we're processing sulfite is via an enzyme called sulfite oxidase. Now, sulfite oxidase takes the toxic sulfite and converts it into inorganic sulfate. Now, I know that you guys had Stephanie Seneff on, and I think that she would probably have spoken to you about sulfate, because that's something that I know that she's done a very deep dive into. But ultimately, inorganic sulfate is just so important for the human body. But what we need to be able to do is to take this sulfite and convert it into inorganic sulfate to get enough to do what we need to do. And of course, if she spoke to you about glyphosate, she probably spoke to you about how it inhibits the conversion of sulfite into sulfate, and you get a buildup of this sulfite. That's one of the toxic effects and one of the ways in which it kind of really screws up with sulfur metabolism. But this sulfite oxidase enzyme, interestingly, is molybdenum dependent. Now, molybdenum it is a trace mineral, meaning that you don't need that much of it, but there are some things that could increase the requirement. For instance, if someone has a high protein diet, if they have a high amount of sulfites coming in, and then it could be the case that they're not getting enough molybdenum, also dependent on the soil, on their diet. So one of the reasons, or one of the ways that, one of the things I found that can help people tolerate TTFD is actually taking extra molybdenum. This is something that we'll talk about a little bit after. But ultimately, many of the symptoms of TTFD intolerance, if someone takes it, and they might experience like an increased heart rate, flushing, headache, sweating, very similar symptoms to when people have sulfite intolerance. And so taking molybdenum anywhere between 500 micrograms or 1 milligram per day can really help to ease the symptoms and actually allow someone to tolerate that. However, there are other people who simply just don't do well with sulfur compounds. And so for those people, you're going to be wanting to use another form. And we'll kind of go through some examples in just a second. But you'll notice that I haven't mentioned sulbutamine. The reason I haven't mentioned sulbutamine is classed as a nootropic. It's very similar in structure to TTFD. So TTFD is one molecule. You've got this sulfur-sulfur bond with like this sulfur group. Whereas with sulbutamine, you don't have that. You just have one molecule of thiamine, and there's a sulfur-sulfur group, disulfide bridge it's called, sulfur-sulfur group with another molecule of thiamine. And it has very similar properties to TTFD. However, I don't have that much experience with it. I know that there's some people who swear by it and they say that it helps. There's a lot in the nootropics community which say that which use it specifically for dopamine production, etc. However, the issue is that it does tend to have this this is like how to say it. Basically, people can become resistant to it. So the effects start wearing off. They have to take higher and higher doses. And I'm not exactly sure why this is. But generally, for that reason, I've stayed away from it. So I stick to TTFD, and I haven't found as though that anyone has these kinds of problems. So just to recap, all of these forms can be effective clinically. Some people respond to better to one form rather than another. Some people actually respond to a combination of all of these forms. The salts, so thiamine hydrochloride and thiamine mononitrate, these are the least potent, but they're generally the best tolerated. I think because they're less well absorbed, less is getting into the body, and at the same time, there are no extra molecules that the body needs to metabolize or break down in the liver that could potentially cause a problem. Benfotiamine is particularly useful for peripheral neurological issues and diabetes. However, it's just not that good at dealing with central nervous system problems or gut problems from what I have personally found. That's not to say that some people don't respond well, but that is just personally, again, what I found clinically. TTFD, again, It's very useful for brain issues, gut issues. However, there are some people who do not respond very well, and I think this is due to the sulfur group. There are ways to help metabolize that. However, in some people, whether due to genetics or whatever, they're just not going to be suitable for this particular form. Now, we're coming to the clinical application. So how you create the right protocol. Okay. So before anything, you need to understand that if you have a patient who you suspect is either going to be thiamine deficient or thiamine dependent, then you need to educate them on the fact that they are likely going to experience what's called a paradoxical reaction. So the next couple of slides, I have taken quite a lot from the document that we were talking about last week. And ultimately, a very basic definition of the paradoxical reaction is after people begin supplementing with thiamine, they often notice a temporary worsening of symptoms. So this can be the symptoms that they originally had because of the deficiency, or it can be different symptoms, and we'll look at kind of what they most commonly are. This is most pronounced in people who are severely deficient. So if they've had a long-term or very severe deficiency, they're usually going to have to go slower because the paradox is so severe. Now, sometimes it can be putting people in bed, other times it can be super mild. So it really differs from person to person. I have come to the conclusion that the paradoxical reaction can be mitigated to some extent through supplementation with supporting vitamins and minerals. So this is other nutrients which seem to have a interrelationship with thiamine and thiamine dependent processes, which appear to be able to dampen the severity of the paradoxical reaction. So some common symptoms of this effect are fatigue, lethargy, and muscle weakness. These are probably flat out the most common. As I said, some people might be bedbound. Other people may just feel as though they need to take an afternoon nap. This can last anywhere from a week to 2 weeks to 3 weeks, depending on the dose and depending on how fast someone has started. Other things can be anxiety or restlessness. They may feel as though their nervous system is turned on. They may feel as though their digestive system starts working, but even maybe a little bit too fast. So for instance, they go from a position of having low stomach acid to super high stomach acid. And this is why it's called the paradoxical effect or the paradoxical reaction. This was coined by Derek Lonsdale. But ultimately, even if you go back to one of the seminal texts on thiamine deficiency published in the 1960s, it was a translation of all of the Japanese literature up until that point into English. And I've got that book. It's out of print. But what they identified back then was that there were some very classical patterns that you would find among people. And one of the examples was with stomach acid. So they found that, say, one group of people would experience, if they had low stomach acid, they would immediately experience high stomach acid, and then that would go down and gradually normalize to normal levels. In other people, it would go lower, then it would go high, then it would go low, then it would go high, and then it would normalize. In other people, it would just gradually improve and improve and improve over time. So what they discovered was essentially you have these different groups of people respond in completely different ways. And the overall trajectory is upward. So the overall trajectory is that their health issue or the problem that was caused by a lack of B1 in the first place improves. But it can be that the problem flips in the opposite direction temporarily and then comes back to normal. And that can be confusing for some people. You know, if you've had chronically low stomach acid and then all of a sudden you get lots of reflux, you might put that down to the B1 and you might think that you need to stop it because of that. Well, that's not necessarily the case. It can be this concept that the nervous system is starting to work again and that actually it needs to rebalance. And as it's in this rebalancing phase, you get too many signals sent to the stomach, sent to the gastric parietal cells, etc. And then that tends to normalize over time. So you can see a flipping back and forth. For instance, this also applies to blood pressure. You might notice that if someone's had chronically low blood pressure, they can all of a sudden develop high blood pressure. On the other side, if someone has high blood pressure, they can go to low, or they might go up and down and up and down. And this can last for several weeks or even months. And it seems kind of confusing. But if you know what to expect, if you know what to identify, then you can help guide someone through this. You can help them understand that this is a normal something that they're coming along with. And actually, if you see these symptoms change, it's usually a good sign. Okay, it's usually a good sign because it means that the body is doing something. So I did my best to try and visualize, try to lay it out as to how this works in practice. But when it comes to dosing, and again, we did talk about this last week very briefly, but when it comes to dosing, there's something that Lonsdale laid out, a kind of protocol or a strategy, which has never failed me and continues to work to this day. And this is the concept, or basically the paradoxical reaction, the way that it works. If you see from the side, there's symptom improvement. So as the blue line goes up, you see the blue thick line, that is symptoms improving. So getting better. So the lower it is, the worse symptoms, and the higher it is, the better the symptoms, or the lack of symptoms, let's say. And so you see that when you start thiamine supplementation around here, there is a temporary worsening of symptoms. So whatever there are, and it can be different for each person, constipation might get worse, diarrhea might get worse, fatigue might get worse, insomnia might get worse, whatever it is, it temporarily worsens. Again, what will happen then is they'll rebound after a certain amount of time, and it can be days, it can be weeks, depending on the dose, but they tend to achieve a new improved baseline. So the baseline that they achieved is not perfect, but it's slightly better than where they were before. Okay. And then at that point, I go to the next one. So when they've achieved that new baseline, they increase the dose. And as they increase the increased dose almost always coincides with another temporary worsening of symptoms. Okay. So that's something that you need to understand as well, is that whenever you increase the dose, expect symptoms to get worse. And until symptoms at least return back to normal, to what they were before starting, you do not increase the dose. And this is the main argument behind starting low and slow. You know, when I first came across this, I would chuck people in at like super mega doses, and believe me, like they had to pay the price. And I'm very sorry for that, because I was essentially naive and thought I knew better. As it turns out, the best way to go about it, honestly, is to go very slowly and start at a very, very, very low dose. And we'll go through what that is later. But ultimately, always expect a worsening of symptoms to coincide with the increase in dose. So you do not increase. You see the orange line stays stable. Okay. It stays stable until the person has rebounded from that worsening, has achieved a new baseline. So the new baseline symptoms, they're maybe slightly better, or maybe the same as what they were before, but they're not worse. And then you increase the dose ever so slightly. You increase the dose here, and then you notice another worsening of symptoms, but it might not be as bad this time. So for instance, if the first time they increased the dose, the fatigue was 10, next time the fatigue might be 8. Okay. And then it rebounds. And then the fatigue is what? 4 or 5. And you keep doing this, and you continue doing this pattern, but you never increase the dose when the person is worse than they were when they first started, because that will even just make them worse, and it will likely make them hate you. And they might not trust what you're saying, So you need to educate them on this process. Okay. If they know what to expect, then they're going to be less likely to have concerns. Now, there are 3 pillars of thiamine repletion. Now, this applies if you're going to be megadosing for someone who has a neurodegenerative condition, or also if you're just dealing with a bog standard deficiency of someone who has peripheral neuropathy or something like that. So 3 pillars of thiamine repletion. One is a form of thiamine which suits well for the human body, for their individualized biochemistry, and you have to identify what that is. Next, elemental support, and we'll go through exactly what that is as well. At very least, it's magnesium. At very least, usually other electrolytes as well, particularly potassium, oftentimes sodium as well. Okay. And third, B vitamin cofactors. Now, remember the diagram of the Krebs cycle and all of the other biochemical pathways that you likely had to learn in medical school, or whatever kind of educational platform that you were studying. Ultimately, every single B vitamin is essentially working together, either in a direct or an indirect way. Okay. So there are enzymes which require every single one of them. And so the theory is that as you start giving the body a massive dose of one, you are potentially going to be increasing the amount needed of the other B vitamins. So a very basic thiamine protocol. And this is really your foundation. This is what we spoke about last time. The foundation that you should be giving any patient that you are prescribing this therapy is a type of B1, additional B vitamins. So this can be a B complex, either in methylated or non-methylated form. So you'll see a lot of B complexes are methyl B complexes. There are certain individuals who just do not do well with those. It makes them anxious. They've got maybe some genetic polymorphisms that don't allow them to tolerate these B vitamins so well. So in these individuals, you don't use those. You would try to use a non-methylated form, or whatever it is. You just want to try to get some kind of a B complex in their body behind it. Okay. Next is, like I just mentioned, the magnesium is really, really, really essential. You will often find that someone has a variety of negative symptoms if they do not take magnesium. That is really important. But also potassium, I found, and sodium. And we went through this basically last week. But another question that you want to be asking yourself, really, when you're going through your patient's case, you want to be trying to determine, so is this a classical thiamine deficiency? So do they have the risk factors? Okay. Have they a history of alcoholism, history of digestive issues? We went through this on the other presentations. There's a lot of different risk factors. Do they have any of those? If they don't have any of those, then it's kind of odd that they might be deficient in B1. Okay. Do they present with deficiency symptoms? Again, look at all of the different symptoms. Do they have any of those? Do they just have one or two of those? Or do they just have like Parkinsonism? Do they just have Huntington's disease? Is it just like severe dysautonomia, just like 2 or 3 symptoms? They may not have the classical deficiency symptoms that you would read in the textbook. Okay. Do they present with those, or do they present with just one health condition, which has a couple of other things? Do they respond to low doses of B1? So if you were to have a patient, you start them on a very low dose, if they respond immediately, what you're likely dealing with is a deficiency rather than a dependence. And we'll go through the practicalities of that in just a second. In positive responders, so if you have someone, you put them on a very basic protocol like the one we've just spoken about. You find a thiamine supplement. You say, hey, yeah, here's some benfotiamine, great. Here's a B complex, here's some magnesium, and take an electrolyte powder throughout the day. You notice that they have almost immediate improvement in symptoms. They're on that for 6 months. And so they decide, well, actually, I don't want to be spending this amount of money every month anymore. So I'm going to start weaning off of this. So they stop taking the B1, and then all of a sudden their tremors start coming back, right? That is a really important sign, because generally a deficiency is going to take anywhere between 2 to 5 months to address. I mean, there are the very severe cases that can require, 1 year of treatment. You need to be treating these people for, 6 months to 1 year. But ultimately, in most cases, a deficiency will be addressed within like a couple of months. So if you've got someone who is dependent on very high doses for like 6 months onwards, then you should really start to be considering, okay, this person may require this for a prolonged period of time. You're talking years, right? Possibly. And you need to make them aware of that. They need to know that if they come off this, it's essentially you're using it as a medication. And this is what Lonsdale said. And of course, I can't publicly talk about using drugs because I'm not a medical doctor. But really, from let's say a pharmacological perspective, you are using thiamine as a drug. You're not using it as a vitamin in that respect, or you're using it as a vitamin which has drug-like properties in the doses that is needed to maintain someone's health, kind of remission from their health condition, because you're not addressing a deficiency. And as long as you make them, you make sure that they know that. I mean, most times a patient will be more happy. They'll be happy to take a vitamin if it means that, like, not having to take a synthetic drug or like 3 drugs, or not having to have their symptoms regress or progressively degenerate. A lot of people are more than happy to be taking a vitamin for the rest of their life, but that is on the books for many of the people. Finally, do they have a neurodegenerative condition or complex conditions such as fibromyalgia, chronic fatigue, and ME? So in these people, again, it's usually not a deficiency. So as long as they know that, because if people think that, if you lead people to think, oh, well, okay, you put them on a supplement and then they see an improvement and they kind of assume, or you allow them to assume that they had a deficiency, then they're going to want to know when they can come off of it. Because some of these drugs, the forms of B1, especially the doses that are needed, it's not necessarily cheap, right? It's probably not anywhere near as expensive as pharmaceutical drugs, especially in the US, which is insane prices, but it's still not cheap, and you can't get these things on insurance. So this is out of pocket. So as long as they know, keep them in the loop, right? That's all I'm saying. So these things, if you answer these questions, you're going to be able to decide whether this person is deficient or whether you've got this dependence. And that might also determine which protocol you're going to keep them on or put them on as well, because they are different and they generally do change. So key points: there is no maximum dose of any form of B1. I mean, you will usually not be going anywhere above 2,000 milligrams unless it's diamine hydrochloride. But even then, I mean, there are some people who require much higher doses, but it's very rare. I would not go anywhere above 2,500 milligrams, really, because it's usually just a waste of money. So, but for what it's worth, from a safety perspective, there's no maximum dose. The dose can be increased based on symptoms. So we're going to be looking at protocols in the next section. The dose could be increased based on symptoms. Basically, you'll understand what that means, but you can personalize these protocols. They're not set in stone. There is no exact form or exact dose that someone needs to start with or finish with or get up to. It's really based on each individual patient, and that's where you'll need to keep very close track of what's going on. Now, full recovery, if someone is looking at deficiency situation, it can be anywhere from 1 month to 1 year, like I said before. Now, when to reduce the dose, some people find that only 1 to 2 months of taking B1 is sufficient to basically bring them up out of this state of despair, physiological imbalance, and that what you will notice is that they will stay on the dose that helped them, but the dose that helped them actually starts to make them feel worse. So oftentimes it won't be a regression in their original symptoms, but it will usually be like insomnia. They all of a sudden can't sleep very well, or they get anxiety or jitteriness, or they feel a little bit hyper energetic. Sometimes it differs in the way that they describe it, but I think you understand what I'm saying. And that's generally a sign that someone's taking too much. Now, that's also a very good sign, because what you'll find is that is the point when you can start reducing the dose. Alternatively, if they've been on it a couple of months, they're feeling great, they're feeling like they've got lots of improvement, you can say, well, actually, maybe let's try to reduce the dose. Let's try to reduce it and see how you feel. And sometimes they feel great. Sometimes they feel even better when they stop. And that's excellent. And that's exactly what you're looking for. Okay. Now, in putting together a protocol, you will know how to choose the right form. We went through sulbutamine, TTFD, benfotiamine, thiamine, HCl. You need to know which one to go for. What I didn't mention was mononitrate. Now, some people use mononitrate. I don't really have any clinical experience with it. I think it's got the least the worst absorption profile. It is something similar to thiamine hydrochloride, but slightly worse. So if someone can't get anything else, then thiamine mononitrate is probably the worst case scenario. It's better than nothing, but I would really try to aim for some, at least thiamine hydrochloride, maybe some of those better absorbed derivatives, really for optimal levels. But so for beginners, there is no correct form. Like I said, it's highly individual. Okay. The best form is based on individual needs and tolerance. You need to determine where you think which form your patient is going to tolerate the best. And this is by knowing their history and knowing what they react to and what they don't react to. Each form has benefits and drawbacks. So I'll give you an example. How might you determine you've got someone come into your office and you're thinking, well, okay, I've got this B1, and this B1. They're all different ones. Which one do I give? Well, okay, remember, come back to what I said. Okay, TTFD, or come back to what I said about the different forms. Benfotiamine, excellent peripheral problems, excellent for diabetes, excellent for anything in the periphery. Okay, thiamine hydrochloride, really good for sensitive people. TTFD, really good for anything brain-based, anything gut-based. Okay, so example one, here's a patient. Been diagnosed by the neurologist, some kind of primary dysautonomia, maybe it's POTS. Regularly experience brain fog, regularly experiences dizziness when standing, etc. Typical POTS symptoms, has constipation and also gets acid reflux. This is the kind of patient that requires laxative. It's the kind of patient that is constantly taking high amounts of magnesium citrate, prune juice, etc., just to go to the toilet. And maybe they're even bedbound because whenever they stand up, they get dizzy and really high heart rate and things like that. So you look at this patient and you see, whoa, okay, very clear issues. Come back to this concept of dysautonomia as being a brain-based thiamine deficiency in many cases. You say, okay, brain-based. You inquire, you say, well, okay, TTFD. I know that TTFD is good for the brain. However, there is also this problem that Elliot said that TTFD also contains a lot of sulfur. And so people with sulfur problems might not react to this. So you ask them, you say, okay, how do you do with eating garlic? TTFD is probably the most similar chemically to compounds in garlic. Okay, that's actually where it's derived from. Allithiamine derived from garlic. TTFD is a synthetic version of allithiamine. So allithiamine, the thiamine found in garlic, is super similar to TTFD. A lot of the molecules in garlic are similar to the sulfur molecule in TTFD. So you ask, how do you do well with garlic? How do you do well with onions? How do you do with cruciferous vegetables? By some chance, do they ever take sulfur-containing supplements? I mean, depends what kind of patient population you're working with. With people who come to me, nutrition, functional medicine, they're generally taking a lot of supplements anyway. But if you're dealing with the general population, they might not. So they might not even know. But it's worth asking how they do with some of these very classical sulfur-containing vegetables. Now, if they do okay with that, there you go. You've got a green light to try TTFD. Chances are they're going to tolerate TTFD. They still need to start slowly, and we'll look at how to do that. They'll need to start slowly, but chances are they're going to respond well. Okay, example 2, you got diabetic peripheral neuropathy, chronic back pain, and they're obese. Well, you could use TTFD, and in some people it does help, but really where the research indicates this is useful for, and clinically, benfotiamine all the way. Benfotiamine all the way. And usually within 3, 4, 5 days, they can get a hold of the chronic back pain. They can get a hold of the peripheral neuropathy once they get up to those high doses. Okay. Benfotiamine. Another example, someone also comes in, central dysautonomia, gastroparesis, maybe they've got fibromyalgia. They've got a lot of these issues that you know that I've spoken about, respond to B1. And you think, oh, well, okay, I feel as though this might be a brain-based condition. And I know that TTFD can be useful for that, but then you inquire about how they respond to sulfur-containing vegetables. They say they have a very strong reaction, a negative reaction. Someone can't eat garlic. No. It gives them lots of gas, gives them headaches. No, they can't take MSM or NAC. They can't consume onions or cruciferous vegetables. It gives them itching, gives them flushing, gives them sweats, those kind of things. These are typical kind of sulfur reactions or sulfite intolerance reactions. It's really common. And these can be managed. But ultimately, you would not want to give this person TTFD. Primary reason is because it's likely to make things 10 times worse. So you would use something like thiamine hydrochloride. These are just very basic examples of the kind of things that you would use them based on the condition. Okay. And these can be mixed and matched. And sometimes it surprises you. So here's an example when things go wrong. So you have patient one, this same patient that had all of these symptoms that you thought, wow, well, this is exactly what TTFD is supposedly good for. And they say that they do well with cruciferous and other sulfur-containing vegetables, but they try it. They get terrible headache. They get flushing, dizziness. And so you say, okay, well, you took a whole capsule of TTFD. That's too much. So let's lower the amount. Let's try you on a minuscule. Let's try you on just a dusting, just like 5 milligrams or something tiny. They get similar response. Now, even after you add some of the cofactors, and we'll kind of look at what those are. Let's say you add in molybdenum, which I go through in my document. If someone has a problem with this type of thiamine, usually it's because of sulfites. And if they take molybdenum, it can help their body process sulfites like we were talking about before. Even after they try that, they still have a negative response. What you would do in this case, and this same thing applies to benfotiamine as well. If you think that they're going to work really well with it, you think they're going to have a positive response to it, and you try everything, which we'll go over next, you try everything that you possibly can, and they still do not respond well after a couple of weeks, then you discontinue the more potent thiamine derivative and you go back to basics. And this is where thiamine hydrochloride can really come in handy. Because if you're working with people who are super sensitive to supplements, then thiamine HCl can be one of those things that is just perfect for those people who cannot tolerate the more potent thiamine derivatives. Remember what we said about how TTFD and benfotiamine, the average of bioavailability is anywhere from like 50 to 95%. Well, with thiamine HCl, it's like between 5 and 10%. Now, also remember when I said the severity of the paradoxical reaction is oftentimes proportional to the severity of the deficiency. Well, what that means is that if you use a very potent form of B1, oftentimes what you find is that the severity of the paradoxical reaction is much higher than if you use a much lower potency form of B1. It's like drip feeding a tiny amount to the severely deficient body. It tends to be able to process that a little bit better. Whereas when you use the very potent derivatives, it's almost like too much of a shock to the system. The body can't deal with it. It's already in a mess and it just makes things worse. I'm not saying it makes things worse medically, but in terms of how they feel and in terms of their relationship with you and whether they trust you or not, don't make the mistake that I did and use super high doses of the really potent forms, because these forms are they're real powerful, especially in the high doses. So what you would do is you would go back to a very basic thiamine hydrochloride. That's where it's a very low dose. And ultimately, you can try other forms later on. They can be layered on top. Okay. So in general, TTFD, people who do well with sulfur, who have brain-based conditions. Benfotiamine, very good. Peripheral, diabetic, pain of any kind, obesity even, usually very useful. Thiamine hydrochloride for those very sensitive individuals or people who can't gain access to the more potent or more expensive derivatives. Okay. So here we are. So here's a very basic protocol. This is taken from a document. And this is a pretty good baseline, I think, that you could probably use in most patients. Now, this is something that can be used in patients who you suspect are deficient, or it might be used in people who you think have have neurodegenerative conditions, who you think might have this thiamine dependency, but you don't want to chuck them in on a super high dose, first of all, because they tend to be quite sensitive. So this generic protocol example is really designed to be starting very slow and going very slowly. And this is the key point from the protocol, is to start at a low dose. Remember, the RDA is 1 milligram. So even if you're giving 10 milligrams, you're giving 10 times the RDA. That's a lot. Okay. It's a lot. So what you would want to start with, again, coming back to that foundation, you want to start with some thiamine hydrochloride. It can be low dose pills. It can be hydrochloride powder. There's lots of companies that sell all of these forms. You might also want to get them to invest in some kind of a derivative, whether it be Benfo, Solbu, or TTFD, depending on their individual makeup, and you can decide that. A multi-B vitamin complex doesn't have to be high dose, just very basic, and magnesium as a minimum, also potentially an electrolyte, like I said previously in the presentation. Now, the first stage, in the first week, you would start them, depending on how sensitive they are, you'd start them on anywhere between 10 and 50 milligrams. Now, remember, at a low dose, the transporters are saturable when you're using thiamine HCl. And what that means is that you're probably not going to be absorbing most of that at all. Okay. You're probably only absorb 5 to 10%, but that's okay. So you would start them on 10 to 50 milligrams. If they're super sensitive, it would be 10. If they're not very sensitive, it would be 50. And you gradually increase by 10 to 20 per day. So if you get 50 milligram capsules, you would get them to open that up and just take half, like 20 milligrams. Okay, 25 milligrams. Just take half. And then on another day, they take a full capsule. And then a couple of days later, they would take 1.5 capsules. A couple of days later, they would, take 2 capsules. And that way you would be very gradually increasing the dose. Now, stage 2, I've put in stage 1, approximately lasting 1 week. If you've got someone who's severely deficient, severely sensitive, then this isn't necessarily it might be 2 weeks or 3 weeks. Okay. So this is approximate. Stage 2, when they're at about 200 milligrams thiamine hydrochloride, that's when you increase some of the other cofactors of the B complex, etc., as I've laid out here. And they continue increasing very, 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 very slowly by the HCl. Okay. Stage 3, 400 milligrams HCl. That's when you can start adding in a more powerful derivative. You do not want to start with the derivative in someone who's really sensitive. Okay. Because it might just tip them over the edge, make them feel 10 times worse. They might say to you, look, I'm never taking thiamine again. It makes me feel so bad. I've heard it sometimes, honestly. And oftentimes that's how you know that they're the people who need it the most. And that's the really unfortunate thing about it, trying to convince them to take something that makes them feel terrible. It's a nightmare. So I highly advise against it. What you want to ideally do is get them to a point where if they can tolerate a good 400 milligrams of thiamine HCl, you can be almost certain that they can start working with the derivatives. Their body has now gotten to the position, and you work up that dosing schedule. Like I said, you start, then you stop when the symptoms worsen. And then you go, as I demonstrated on that chart, you use something like that, something roughly similar. And you'll find that when they can tolerate 400 milligrams, their body is in a position where they can better tolerate derivatives. So I've laid out here, again, when they get to about 100 milligrams of a thiamine derivative, then you can start ramping up the dose again and again and again. Okay. I'll go into a little bit more detail in the document that I did, but again, even if you just have these slides, that is a pretty solid thiamine protocol that you can work from in terms of getting the cofactors. As long as you're getting the B complex of magnesium, the HCl, and a thiamine derivative, and you increase as based on their symptoms, then you should be good to go. Now, here is the megadose protocol example. This is really for the people who are not very sensitive. They might have come to you. They might have tried thiamine. They might have tried quite a high dose of it and not noticed much effects. They might also be the people who have these dependent conditions, the conditions which are not technically deficiency. So Parkinson's, your Huntington's, your multiple sclerosis, your chronic fatigue syndrome, fibromyalgia, these kinds of things. These are the ones where you're going to be wanting to saturate the cells with as much thiamine as you possibly can, for as long as you possibly can. And so the protocol key points is that any form of B1 can be used. If you go back to Costantini's literature, you saw how he would be using thiamine HCl in Parkinson's disease. I personally advise against that. I think you should use a mixture because I've had better results using the derivatives. But Costantini didn't really know much about the different types of thiamine. So you can forgive him for that, Any brand will suffice, as I said. Any form, you can use multiple forms. What I've laid out here are example doses, and they can be modified based on individual tolerance. Okay, so for instance, if I say to increase by a certain amount every week, you can increase by double that amount if your patient feels good when doing it. If they feel great on 300 milligrams and they decide that they want to go up to 600 milligrams, they try 600 milligrams, they feel even better, keep them on 600 milligrams, right? Don't just follow like what I've put here. It's just very basic outline. I do often recommend using the mix and match approach. And what I mean is using different derivatives. There's very basic reasons for this. And if you look at the literature, benfotiamine acts via other ways, or acts via ways other than increasing thiamine in the cell. So does TTFD, so does sulbutamine. What this means is it has kind of, I think pleiotropic might be the right word. It has effects on the cells which are not related to it containing B1, in that the benfo of the benfotiamine, that extra molecular group, has non-coenzyme effects. Same as the sulfur group on the TTFD. They have anti-inflammatory, antioxidant properties, mild chelating properties. They have effects on gene expression, on the expression of anti-inflammatory or pro-inflammatory cytokines or genes involved in the production of those molecules. So I think that it's actually there are effects that we don't know about, that have not been characterized, but that can help to explain why some people benefit from certain forms other than other forms. And I don't think it's just due to the thiamine content. So I generally recommend using a combination. So if you've got someone with a very serious condition, say you've got someone with ALS, you explain to them concept, they're interested, they might read about it and they want to go ahead, then you really don't want to be messing around. Of course, principle still remains. You start low and you go very slowly, but you do it based on how they respond. So if they're not the sensitive type, then you can start at maybe 100 milligrams, and then you might jump up to 200 or 300 milligrams 2 days later. And if they respond well to that, you continue along that trajectory. You ideally want to get a mixture of everything. So you want to get some thiamine hydrochloride. The powder is cheaper, and these people are going to be taking a lot of powder long term. So you want to try to secure a source for that if you can. TTFD, benfotiamine, and sulbutamine if you can. If not, just TTFD and benfo. I found that most people benefit from just those three. Multi-B vitamin complex, again, the very basic foundation, and a form of magnesium that they tolerate. Okay. Now, here is where you can start off. You've ascertained they're not sensitive. So I've put the starting dose for this protocol is 400 milligrams. That would be 100 milligrams of HCl, 200 milligrams of benfotiamine, 100 milligrams of TTFD, or a disulfide derivative. That's a pretty substantial dose to start off with, but many people do tolerate it. So, sometimes you might want to go slower, but, some people might work with this dose. Okay. You start off at 400 milligrams first week. Next week, you go up to 100, 400, 600, you go up to 600 milligrams. Then you go up to 1,200 milligrams on week 3. And you can go up beyond 1,600 milligrams, a combination of all of these different forms by week 4. Now, the stages, again, it's approximate. So it might be sooner or later, depending on how they respond. It might be that they feel great at 1,200 milligrams. They don't feel very good at 1,600. So you keep them at 1,200. You get them to listen to their own body. You figure out, you jot down, you get them to take notes. What dose is their sweet spot? And that's really the thing. Remember that there is an all or nothing effect that Costantini noted with these kind of conditions, in that a low dose, they might not notice any improvement. So it might be that you need to go up to 2,000 milligrams combined in all of the different forms, like together, not 2,000 of each, but 2,000 in combination, until they notice any change whatsoever. And believe me, there are more people like that than you would imagine. So yeah, the best way to identify whether one would benefit or not is to experiment with increasing the doses and monitoring symptoms. Okay. There are various ways to increase that. Some studies have used up to 4,500 milligrams of thiamine in hydrochloride form. Although what I found clinically is that 2,000 to 2,500 milligrams is like the maximum that anyone would need to see benefit. So the things that you really want to watch out for, again, you want to try to ascertain, is this person classically deficient? If they are, you probably want to go with a generic, like a sensitive protocol, starting very low, very slow. If someone doesn't have the risk factors for deficiency, you might also want to try them temporarily on a very low dose. But if they don't really have any significant symptom changes at all, then you can jump right towards a mega dose and you can play around with the different forms. Any change in symptoms. So you're looking for a worsening or an improvement in any symptoms in the first few weeks. This is a positive positive sign in the majority of cases. So for instance, if someone starts to notice a worsening of symptoms, it's a good sign. You stop there, you do not increase. And what you find is that usually they'll improve within a couple of weeks and they'll actually be surprised. And then you can increase the dose. There's some people who aren't like that, but for the majority, getting worse is a good sign, just like getting better is. The worst thing that you could see, honestly, the worst thing that you could see is that there's no response at all. Like that's what you're not looking for, or that's what you're looking for. Okay. If there's evidence or if there's zero change, even after exceeding the 2,500 milligram or 2,000 mark, and this is when you're using different derivatives as well. So you're using your benfo or you're using your TTFD or your sulbutamine or thiamine HL, but you use it, you've tried different forms basically, and you're up, around that 1,500 to 2,500 milligram. If they do not respond, if there's no positive benefit whatsoever, then look, it's a waste of their money. The waste of the time and their money, you should look somewhere else because they are likely a non-responder. And there's a lot of people who don't respond, right? But there's also a lot of people who do respond, and sometimes it's impossible to know who is going to and who's not. That's why I basically try everyone out on it, simply because you just don't know who's going to respond and who doesn't, and it really doesn't correlate with test results at all. So that's why it's really hard. You just have to try. So as long as you keep them in the loop and you say, especially if thing is, your patients, if they've got a neurodegenerative condition, usually they're willing to try anything, because they've basically been told, well, this drug can only prevent the progression. If it's something like ALS, there's not even drugs which help. So really they're most of the time, they're not going to be bothered trying anything out. If there's even a chance that it might help them, or it might even just delay the progression in some way. So that's something to factor in. A positive response coupled with some negative symptoms. So for instance, if you notice that someone has symptoms like fatigue or pain or neuropathy, and they take B1, you put them on a protocol, they say, wow, my neuropathy helped a lot, but all of a sudden I'm getting headaches. Or, wow, my body pain is improved, but actually I'm feeling a little bit bloated. Or, oh, I'm feeling that I'm getting itchy skin. Then what this usually indicates is that, yes, they need B1 and they should not by any stretch of the imagination discontinue B1, but you need to be looking at other nutrient interactions, and that's the last section and we're nearly there. Important points to remember: the all or nothing effect. Like I mentioned, it's real in some patients, so do not give up too early. If you're expecting a response and you don't get it, it might be that the form you've used is not enough, or that the form you've used is not the right one, or the dose is just not enough. Okay. Some people notice zero change until they get to like 1,000 or 2,500 milligrams. Okay. Then it's like overnight change, abrupt reversal of symptoms. You need to coach the patient to continue in the name of experimentation, often when they've been given like terminal illnesses or neurodegenerative conditions, like I said before. Okay. Now, to create health condition specific protocols, Esther mentioned last week in my document, I have lots of condition specific health protocols. You don't necessarily need that to come up with your own. Ultimately, there is the foundation. So if you know that there's a thiamine responsive condition, thiamine and the associated cofactors like the foundation that I've spoke about is not always going to be the only thing. It's that, for instance, if I've given the example of someone with an underlying digestive dysautonomia or underlying digestive dysfunction, so gastroparesis or constipation. Now, the foundation is going to be your B1, is going to be your B vitamins, your electrolytes, and your magnesium, like we spoke about. But that doesn't necessarily mean that you're not going to use things which also can help that process. So if you know that they have pancreatic insufficiency or even mild pancreatic insufficiency, you would prescribe digestive enzymes. If you know that they have light-colored stools or they have difficulty digesting dietary fat, then you could prescribe TUDCA or bile acids. These things can help the body process dietary fat. Okay, they can help the liver process come up with its own bile salts. In the case of TUDCA, CDP, choline, alpha GPC, pantothenic acid, vitamin B5, Bacopa monnieri. These are three things which can help the acetylcholinergic system or the cholinergic system in the gut. So for instance, like we were talking about last or even earlier on in this presentation, how you have one of the main presentations of B1 deficiency in the gut is SIBO, or digestive shutdown. So you lose the ability to make enzymes, you lose the ability to properly propel food, you lose motility. Then a lot of that has to do with this shutdown of the cholinergic neurons. So not only do you try to reawaken that or reinitiate those processes using B1, but you also use the things which also have been shown to help that, So you don't have to just stick with this one protocol. It's like, this is a foundation that other things can be layered onto. And another example, got someone with a heart condition or someone with fibromyalgia, you know that there's very specific nutrients which can help with those conditions. CoQ10, for instance, creatine, D-ribose. These things can be layered on, so you can mix and match them together and use your underlying knowledge already to come up with an effective protocol. So recap, to start low, go slow in everyone, ideally, but you're going to listen to your patient. You're going to listen to what they say and how they respond. Protocols can use combinations of different thiamine derivatives. Some people exhibit an all or nothing response. You need to keep this in mind at all times. Some people are non-responders, so you need to learn to manage their expectations and keep in mind what dose to look out for. In people who are dependent, they may require supplements, thiamine supplements indefinitely. The way to know is to observe how symptoms change after discontinuing the supplement gradually. So this is going to be something that you're going to want to try in everyone. If you've got someone who's responded marvelly to megadose B1, at some point when it comes to 2 months, 3 months, 4 months, 5 months down the road, you're going to want to try to wean them off. Reduce the dose very gradually and see how they respond to that. If their symptoms regress, you get them immediately back on B1. Okay. And then you try in another couple of months and you keep trying that. And it might be the case that in a year or 2 years, they can come off of it, but it might also be the case that they can't. So that's a discussion that you need to have. Okay. In people who are classically deficient, they can usually come off in a couple of months. Now, managing patient reactions. This is the last section, balancing micronutrients and the paradoxical reaction. Now, look, I could talk for 20 hours on this concept, but we come back to this concept of the paradoxical reaction. And I have personally found that you can manage a lot of these symptoms, or we could reframe the way in which we view the paradoxical reaction to be an underlying nutritional imbalance in one of the other nutrients, which is going on underneath the surface. So when you take a high amount of B1, then it creates an imbalance somewhere else down the line, and this is leading to one of the odd symptoms. Now, presenting symptoms can therefore be, or they can provide valuable insight into the potential underlying nutritional imbalances that are driving the symptoms in the first place. Like I said, there are direct nutritional interactions between B1 and other nutrients. This is not all of the B vitamins, it's not all of the minerals, but this is where the research has shown some kind of a direct interaction or indirect interaction. So key examples are, for instance, if you start a patient on high dose B1 and then all of a sudden you see that symptoms, they develop poor appetite, they develop tremors, they develop classical symptoms of magnesium deficiency, then you need to up the dose of magnesium. Sometimes what you'll find is that someone needs 600 to 800 milligrams, even 1000 milligrams of magnesium, and you'll find that a lot of these symptoms can improve. Same goes for potassium. And I go through here the nutritional interaction between potassium and thiamine, why there is this kind of increased demand when you're taking B1, when you're readdressing a thiamine deficiency. As you do this, demand for potassium increases. And what you'll find is that sometimes some of the most common symptoms of people who take megadose B1 or have the paradoxical reaction, even when they start a low dose, is going to be these symptoms. And many of them can be addressed by using potassium either in the form of coconut water or in the form of a potassium supplement, like I discussed last week. Another really common one is riboflavin. If they get dry lips, cheilitis, sensitivity to light, or seborrheic dermatitis, so they might develop like strange red rash on their skin for no apparent reason. Again, it's usually an increase in demand for B2. Likewise, if someone develops hair loss, some people see that the hair starts coming out very kind of mildly, not like alopecia, but kind of very mild, or they'll notice brittle nails or something like that. It can also be an increased demand for biotin. Understand that the B vitamins, they do have an interrelationship with one another. And so when you increase one, you can create an imbalance somewhere down the line. Now, that's not a reason not to do it. Okay, that's clear. It's not a reason not to do it. It's just you need to ideally educate yourself on how to identify biotin deficiency or how to identify riboflavin deficiency. I've given you 4 examples here. Honestly, in the document, I go through all of the direct interactions that I know about. Unfortunately, it would take me probably hours to go through every single one of them. And I'm aware of the time, but if anyone has any questions about that, do let me know and I can send you some info. Patterns on testing. So finally, just to finish up, we went through briefly what you might look at on a blood test or in a plasma amino acids, what you might see. I covered these markers last week. There are also some other markers which would likely be high, and these would be on an organic acids test. This is something that if you are signed up with any of the private labs, you might run some of these, particularly the functional medicine labs. But these are a way to identify underlying imbalances. Again, I don't think it's completely 100% accurate, but it can give you a rough idea in someone who you're not sure about. So these are the markers that you might see elevated on an organic acids test. You might see these. This is what it might look like. So lactate, we know that glucose, we knew that thiamine is needed to convert pyruvate into acetyl-CoA. So if you don't have enough thiamine, then you end up with a black log of pyruvate that spills up into lactate, and so you may end up with high levels of lactic acid and or pyruvic acid. Same with alpha-ketoglutarate, otherwise known as 2-oxoglutaric acid. This can also be elevated. However, what I would say is that do not rely on one of the tests to rule out this problem, because I've had countless individuals who have normal organic acids tests, nothing shows up out of the ordinary, and yet they respond marvelously to B1. So that is everything on my end. Thank you so much for watching. Thank you for listening to this discussion. I hope that you have some better insight, or at least a basic foundation from which to begin to start recommending this therapy to your patients. I have sent this presentation to Esther. I would hope that it gives you the basic principles with which to start, the doses to start at. You hopefully have a better understanding of the different forms and why you might use one form and not another form. The only thing that I can emphasize is do not start too quickly. Do not start at too high of a dose. Also, do not rule someone out if they do not respond to lower doses, because you would be amazed at the amount of people who require super high amounts from one day to the next, and then you see that their symptoms drastically improve only when they reach a certain amount. So there's lots of it's kind of a work in progress. There's no exact science to this. That's why I said it's more of an art than it is a science. You need to really listen to your patients and try to continually adapt to how they're responding to this therapy. But honestly, I've basically dedicated my life to this subject because I believe it's so important, because I've just seen so many people respond to it, and practically no one even talks about it and knows about it. So I would really like for people to also share the benefits of this, and if you're working with your patients, and hopefully you can share this with them, and, touch wood, even if one of them is helped, even if one of your patients, of one of you people listening, has the health turned around by this, which I no doubt you will find one person who does respond, then it was worth it. Right. So thanks again. And I guess I should stop sharing my screen now.
Thank you so much, Elliot. It's so beneficial. I can really see, as you're talking, I'm thinking of people. It's just going right through my head. There's so many people that can be helped by this, and I hope we're able to. I want to remind everybody that on Elliot's website, he has this wonderful guide here, all about it. And again, it's not, as he said, it's not just about B1. It's called Protocols for Addressing Thiamine Deficiency and the Paradoxical Reaction. So you can look up, for example, we have here, I printed this out. It's an ebook, but I don't like reading on the internet, so I printed it out. So here he has diabetes type 2, key features of this condition, common signs and symptoms, and therapy aims. And then he has, I'm just using this as an example. He's got many conditions in here. How to improve insulin signaling, improve cell energy metabolism, redox status. It's a terrific guide for any practice, and I highly recommend it. Last week, I had barely had a chance to look at it. This week, I took a look at it, and it's a wonderful guide to have in your office until you start feeling really sound and safe with what you're doing. I think it's just a terrific thing you're doing, Elliot, and what you've done here, and how much you're showing us, and all the work you've put into this, and translating from Asian languages. I can relate to that. Living here in Israel, and I have to translate the Hebrew, these complex things, and put them through Google Translate. And some of the things that come out are quite hysterical. So I'm sure that's not what's meant. But we really thank you so much. We're not going to speak about any specific patients. It is late. General questions only. Next week, Elliot's going to come back, and we can have our patients that we have in mind. We can give him some case histories, and he'll be happy to guide us through with whatever we need to know in order to help these patients. You've got a lot of nice comments here about your presentation. Everyone's very happy. Ephraim, you have your hand raised.
Yeah, I do.
Yes.
I'll lower it. Elliot, thank you very much. It's clear and loaded with all kinds of information. Quick question: what do you do when you have, I'll give an example. I have a kid with 12 years old with Hashimoto's disease. How would you differ in starting someone like that on thiamine therapy? Is there any difference between obviously adults and children?
Yeah. Okay. So thiamine is one of those nutrients which has a great safety profile. Generally, for children, you would the dose equivalent depends on the body weight, right? Although most of the studies have used anywhere, I mean, they would start from like 50 to 100 milligrams with children. For instance, 100 milligrams was used in babies of TTFD, and TTFD is notoriously well absorbed and high bioavailability. And they were injecting that into like toddlers or in newborns, for instance, in some of the Chinese studies with very good results, infantile beriberi, for instance. And they would go up quite high in the dose. So in terms of a child of 12 years old, you could probably halve the doses or do 2/3 of them, but really it would be very similar principle. You'd start very low. So you'd start at 10 to 50 milligrams, and then you'd gradually just build up from there. So you might find that they actually do better with something like 200 milligrams as opposed to 400 milligrams or something like that. Okay. So the key is, I mean, for everyone who you're unsure about, you would just start very slow. You'd start at like between 10 and 50 milligrams per day. And that's safe for every age group,
Have you had any experiences? We get a lot of psychiatric cases, especially now that so many people have had these COVID shots. It seems to be coming out more and more. Have you had any experience with treating psychiatric cases with the B1?
Yeah, there's a lot of bipolar. There are some cases of schizophrenia which respond well to B1. I mean, it would usually be, I clinically would never do that in isolation, right? It would always be behind a diet. So for instance, with schizophrenic or bipolar or something, you would always be trying, at least from my perspective as a nutritionist, I would be trying to get them more towards a lower carbohydrate or more of a ketogenic type of approach, just because of the potential benefits that can have for the neuropsychiatric conditions. It depends on the culture, I guess, and depends on the individual. But in terms of the research, yeah, there's a bunch of research looking at a variety of different conditions which fall under that category in relation to B1, because it relates to this excitotoxicity hypothesis, right? In that if you look at a lot of the underlying literature, it's looking at brain cell metabolism in something like schizophrenia, for instance. There is this hyperexcitability, or there is this neuroexcitotoxicity. There's always some level of mitochondrial involvement, it would seem. And so wherever there's mitochondrial involvement, wherever there is evidence of any kind of bioenergetic cause or hypometabolism as a driver, B1 can potentially be useful. There's also evidence showing that it has certain effects like on dopaminergic neurons, cholinergic neurons. For instance, for seizures, vitamin B1 is really excellent, assuming that the seizures are not cholinergic. And I think that most aren't. Unfortunately, I get many people messaging our company, messaging me saying, look, can I use this for seizures for this particular individual? And I can't give a yes or no answer. Of course, I can't give medical advice or can't give health advice unless it's not in a consultation. But even worse is I say, look, you need to discuss with your neurologist whether it is cholinergic mediated seizures or not. Because if it is, then B1 can potentially make that worse. Whereas I think in 80% of cases, B1 can help. I mean, I've just got so many testimonials of people who basically manage their seizures at least partially with diet, but also with thiamine and especially TTFD. Several Asperger's autistic children who have seizures. That's another thing, autism, right? Lonsdale worked with a lot of his patient population was autistic. So he was a pediatrician at Cleveland. And allithiamine, particularly TTFD, was studied in autistic children. It was a very small scale study, didn't have much funding, and it showed like mild benefit. Now, I've had several children who've regained speech after vaccination injury using TTFD. Okay. So children oftentimes who are, they're starting to gain speech around one years, then they're kind of hitting all of the developmental milestones. And then all of a sudden they get their first vaccine or their first set of vaccines or something like that. And then they progressively, it's usually not within a day or two, it's usually within the space of about a week or 2 weeks or 3 weeks, they start to progressively go downhill. And then all of a sudden they're nonverbal. Well, I have at least 3 sets of parents whose child regained verbal fluency, at least to the point where they were prior to going downhill, using TTFD. And of course, other nutrients. So you're looking at your other B vitamins and things, but TTFD was thought to be the driver. So big with brain-based or neuropsychiatric conditions. It's always worth a try. Any form of B1 as well. This is not just TTFD. Benfotiamine in particular can also be really useful for those kinds of people. Sorry if I went on a bit of a tangent there.
That's wonderful. It's very encouraging. The fact that it's safe and there's no serious side effects. I mean, they might be uncomfortable for a little while, as you had told us, but the fact that it's safe, it's not expensive, is certainly worth a try. So again, I'm going to thank you, and next week, same time. Thank you so much. This time it'll just be an open forum of questions. So a lot of people had to get off because they had patients, they had, so the Zoom is always moving with people coming on and coming off as they can. And here we have somebody logging in now. So next week it'll be an open forum with questions. I'm going to post to the group that people should make lists of the patients. And as we're listening, everyone, if we already hear a patient that's similar to ours, then we can just, move on, because I'm sure, Elliot, you've given us so much of your time between last week and this week. You're so generous. I don't even know how to thank you for what you're doing. And I'm going to thank you on behalf of everybody here and all of our patients. And we're really looking forward to good things. So thank you.
I have to thank your new wife too, Elliot.
Yeah.
I will thank my new wife from you.
Yes.
Thank you very much.
For all of us.
It's a pleasure. It's a pleasure. There's just one question on the thing that I saw. They asked about allithiamine. Please comment on allithiamine since it is available. Okay, so allithiamine is a brand name. Allithiamine is a brand name for TTFD. So there's 2 companies who sell TTFD in the Western world. You can find TTFD in Japan under the brand name Alinamin. There's 2 companies in the Western world. There is Ecological Formulas, and they sell a product called allithiamine, but allithiamine is not actually the chemical or the molecule allithiamine, it's TTFD. Just like Thiamax is the other brand, or Objective Nutrients, my company, we sell Thiamax, that's TTFD. So allithiamine and Thiamax are the same chemical compound. Now, there's some people who claim to sell allithiamine as in the actual compound derived from garlic. However, the Japanese originally decided against using that because of how unstable it was. So anyone who claims to sell allithiamine, either they're selling TTFD or they're selling a product which is like not chemically advised to take. There's not really any research on people taking straight up allithiamine. Most of the allithiamine in the literature is actually TTFD, which they synthesized in the 1960s.
Wonderful.
Okay.
Maybe, when I went to your website for your supplements, I saw that you had a lot of different supplements there. Maybe at the end, after the doctors have had a chance to question you, you can just explain to us what some of those different products are. And
yeah, of course. Yeah.
Clearly, clearly you know what you're doing. And rather than just buying from companies that are randomly putting things together, personally, I would feel very comfortable buying from your company, knowing that you're sourcing. I'm assuming that because you seem to be so thorough, that what you're sourcing is probably going to be excellent quality and exactly what people would need. So it would be very good, I think, at the end of the presentation, next time anyone who's interested in hearing about your products, that you can explain them to us.
Yeah, of course. I mean, the reason I made them was to not have to give people 8 different supplements. It was like, okay, here's the mineral side, here's the vitamin side, here's the thiamine. There you go. Take those 3 things rather than have to micromanage things. That's basically why, that is the company, right? It's like me doing these protocols because, it makes it easier for people. So, yeah, we can talk about that next time. I understand it's late for you.
Yeah, but just feel free next week. If we're asking you questions and you're saying, dose them with this and dose them with this, you can say, and there's this product that I made that makes it a lot easier for you, because quite frankly, we're all so busy, and to have to write out this whole thing, if you just say this
Right.
product, it's going to save us so much time and energy, and it'll be so good for the patients. So
No, I mean, in all fairness, as you know from the document, like I have both the generic protocol, which I went through in this presentation, and I have the objective nutrients protocol. That's easier. But again, like, I don't want to seem like I'm just trying to sell my products, you know, because I'm actually not. Rather than me trying to come across as though I'm like, okay, yeah, take this supplement and take this, and actually you could buy it off my company. But I understand from your perspective, you want it easier, but I hope you can understand my perspective.
yes.
I'm not trying to sell you an idea to make a profit off of it. I genuinely I want people to use this therapy because I have so much faith in it. So yeah, I don't want anything to cloud people's perception of that in terms of my monetary gain. So you understand.
You are clearly a sincere person, and that sincerity comes through. We know you've given us the disclaimers and everything, but sometimes there's an appropriate time. So if you are comfortable, it would make it so much easier for us. So thank you everybody for joining us, and we'll see you next week. And put your case studies together, and hopefully we'll learn a lot next week on a practical level. Thank you so much, Elliot. I have no words. I don't even know how to thank you enough for what you're teaching us. I'm going through all these people in my head, and I'm like so excited. I can't wait to call them and say, hey, we have something for you. We didn't know we could treat you, and now let's try this. Maybe it'll work. It's very exciting. So thank you.
Excellent. Thanks for having me on, and have a lovely week.
Thank you.
Bye, everyone.
Okay, bye, everyone.
Bye.
Bye.
Thank you.